Okay. Good morning, everyone. I'd like to call to order our Behavioral Health Committee for September 7th. Welcome back, everyone. Madam Clerk, would you call the roll, please?
Chair Brayback.
Here.
Representatives Arbit, Pahutsky,
Here.
Glanville,
Here.
Edwards,
Here.
McDonald,
Here.
Rangans,
Here.
Schmaltz,
Here.
Hoadley,
Here.
Saint Germain,
Here.
Thompson. Thompson. Madam Chair, you have 10 members present. You do have a quorum.
Thank you so much, Madam Clerk. I appreciate it. Rep. Pahutsky makes a motion to adopt the June 7th minutes. Hearing no objections, the minutes are adopted. So, like I said, welcome back, everyone. We have several things that I know folks are working on in terms of mental health care, and they'll be coming in front of our committee here. Again, we have to go through the process of going to health and then those things being referred to our committee. Today, we are lucky to have two national experts with us, David Lloyd and Angela Kimball, who are here to kind of really set the table for us in terms of what's going on at the federal level and the federal activity around mental health care as a jumping off point for us as we embark on our work during this season. So I want to thank them both for being here, and I will let them take it away. And they're both on Zoom, obviously.
Thank you, Chair Brayback. Really appreciate the opportunity to speak with the committee today. I'm David Lloyd, Chief Policy Officer at the Kennedy Forum. We're a national organization founded by former Congressman Patrick Kennedy, who was author of the Mental Health Parity and Addiction Equity Act of 2008. So happy to speak with you today about the Federal Parity Act and these issues. I'm joined by my colleague, Angela Kimball, who I'll let her introduce herself, and she's with Inseparable. So Angela, why don't you introduce yourself, and she'll start us off, and then I'll talk more about the details of the Federal Parity Act.
Thank you so much, Chair Brayback and members of the committee. Just appreciate so much the honor of being able to speak with you today, along with David, about what is happening around the country in terms of behavioral health care. I'm Angela Kimball. I'm the Senior Vice President of Advocacy and Public Policy with Inseparable. Inseparable is a relatively new, founded in 2020, just as the pandemic began, organization that is founded basically on the belief that we should be advancing policy that reflects the fact that the health of our minds and of our bodies is inseparable. And we're focused on kind of three core areas. And the primary focus is really increasing access to mental health care. And what we have found across the country is that without access, obviously, people just don't get the care they need. And what we're hearing is that emergency departments are filling up with people who need mental health and substance use care and haven't been getting it. We are hearing about jails and prisons that are overrun with people who need treatment and haven't gotten it. And frankly, we've been hearing from emergency responders, homeless providers, and these are things that you have probably already heard from your constituents, from entities that work in your districts. And what we've heard locally in Michigan is the same kind of needs that we're hearing across the country. And I want to mention that recently the National Governors Association published a youth mental health policy playbook. And in part, that's because governors across the country and across the aisle are recognizing that mental health and substance use is affecting youth in particular, and it's having a profound impact. And as a result of that, we're actually seeing legislators all across the country take very significant steps to try and increase access to mental health care. But to back up a little bit, in Michigan, we've been fortunate enough to work with the Michigan Health is Health Coalition, which is made up of a number of organizations, including the Michigan Association of Social Workers, of psychologists, of counselors, and a number of other organizations, including the Michigan Health and Hospital Association. And one of the things that we've heard hospitals say is that, when an individual is in the hospital and has a heart attack, insurance plans routinely approve the number of days of hospital care that a patient needs based on what the doctor says is clinically needed. And what they express to us is it's different with behavioral health care. With mental health and substance use, there's a strict limit often put on care, and it isn't related to the clinical needs of the individual. And one of the ways that we have seen this play out is a young woman in Michigan who had an eating disorder and was discharged from the hospital too early. Then subsequently developed a substance use disorder, became suicidal. We heard another instance of a health plan who denied a family who has a child with autism applied behavioral analysis, and their behavior deteriorated so significantly that they were subsequently hospitalized. Another story that I heard that has really struck me is a therapist who talked about his clients and how hard it is for many of them to admit that they need help. He serves a lot of clients who come from historically underserved populations. And when their health plan denies them further treatment, they often feel like they're not worthy and they feel hopeless and they give up. So these challenges aren't benign. They result in very real struggles for individuals and families across the state. It's happening across the country. And one of the stories that has struck me most is a story of emergency responders in Michigan having to make life and death choices that haunt them as a result of people with very severe addictions who haven't gotten the treatment that they need. And now they're in a situation where they're facing death by overdose. In short, we really can't wait. All states need to address the mental health crisis, and we're really fortunate to be working in Michigan, particularly with David, my colleague here. He is hesitant to tout his credentials. He is a national expert on mental health and substance use disorder parity and patient protections. He's on a first name basis with the Department of Labor and other entities in our federal government, and has advised numerous states on coverage laws and patient protections. And so with that, I'd like to turn it over to David to really explain what's happening at the federal level and what are some of the steps states are taking to actually address access to mental health care.
Well, thank you, Angela. And yeah, I've been working at the federal level for many years now on mental health and addiction parity. And so I wanted to start by giving a little bit of background on the Mental Health Parity and Addiction Equity Act of 2008. This law was passed on a bipartisan basis in 2008 and signed by President George W. Bush in really an attempt to address long-standing issues in mental health and addiction coverage that resulted in people not getting the care they need. And prior to 2008, there were the situation with health insurance was that many services for mental health and addiction simply were not covered. Many people with mental health or substance use disorders, couldn't purchase insurance, or if they were able to purchase insurance, their mental health or substance use disorders, were not, didn't have any coverage in those policies. And they also, were subject to higher copays and deductibles for mental health and addiction services. All of these served as barriers to people getting the mental health and addiction services that they need, because most families simply cannot afford to pay for these services out of pocket. just like if an individual has cancer or diabetes, they couldn't afford to pay for those services without health insurance. So in 2008, there was this bipartisan effort in Congress. Our founder, former Congressman Patrick Kennedy, was lead co-author of the Mental Health Parity and Addiction Equity Act, along with his Republican counterpart, Congressman Jim Ramstad from Minnesota. And it was passed on a broad bipartisan basis. And at heart is an anti-discrimination law. It says that coverage for mental health and addiction services needs to be at parity with medical, surgical, or physical health services. And it broadly has three main kind of buckets within the Federal Parity Act that has rules on what health plans need to do. The first says that for things like financial requirements, these are the patient cost-sharing responsibilities, that broadly speaking, health plans cannot charge higher copays, co-insurance, or have other financial requirements that are higher for mental health and addiction services than for physical health. So that's kind of the first important component of the Federal Parity Act. The second relates to what are called quantitative treatment limitations. And these are essentially day or visit limits that health plans put on how much treatment an individual can receive under the health plan policy. And so, for example, a health plan policy may say that mental health outpatient visits are limited to 10 visits a year. We think that's inappropriately low, but a policy could say that. And so under the Federal Parity Act, though, it would not be allowable for a health plan to say that there's 10 visit limit on mental health visits a year, but there's no limit on physical health visits a year. That would violate the Federal Parity Act's requirements. So both of these requirements, the requirements relating to copays and deductibles and coinsurance, as well as day and visit limits, they've been pretty straightforward to both analyze and see where there are issues. You can look at the plan policy, and you can see whether or not plans are compliant. And there is a very specific test and calculation that can be done, to determine whether plans are meeting their responsibilities. And because of this, there's been widespread compliance in these two areas. We've seen most of the issues, in these areas resolved. But that doesn't necessarily mean that people have access to care. There's a whole other bucket under the Federal Parity Act that refers to treatment limitations that are what are called non-quantitative in nature. So these are things like prior authorization or step therapy requirements that can limit access to treatment, but are not specific numeric limits on access to care. And so this is an area where there have been the most problems. And these are plans, managed care practices that can inhibit access to care. Additionally, even things like provider network admission requirements. So essentially, when providers are allowed to be in network providers, and even reimbursement rates are also within these requirements of these non-quantitative treatment limitations. And again, these are the areas where there have been the most difficulties and where state and federal regulators have not been able to adequately enforce the rules, in part because the rules that were put in place 10 years ago were not strong enough. And in some instances, have too much ambiguity. So there has been a widespread, recognition that this has been an issue. And so several years ago, on a bipartisan basis, Congress passed legislation in 2020 that was signed by former President Trump that said that health plans had to actually document how their non-quantitative treatment limitations, the things like prior authorization, step therapy, how those limitations that they imposed on mental health and addiction benefits were compliant with the requirements. And these requirements from the 2008 law say that these treatment limitations must be comparable and no more stringently applied to mental health and substance use disorder benefits as compared to physical health benefits. So there has to be parity in how these treatment limitations are applied. And so these new requirements that were put in place by Congress several years ago, again, require that health plans can document how each treatment limitation that they apply are in compliance. Nonetheless, both state and federal regulators have been finding numerous problems, even despite these rules that were put in place a few years ago by Congress. And so recognizing that this continues to be an issue, and frankly recognizing that the initial rules that were put in place over a decade ago have not actually focused in on how the treatment limitations that plans impose affect patient access to treatment at the end of the day. There's been an effort by federal regulators, specifically the Department of Labor, Department of Human Services, and also the Treasury Department, to improve the rules. And so they have proposed new rules this year that would really require that plans collect and analyze data relating to how their treatment limitations affect patient access to mental health and addiction services as compared to physical health services. And where there are disparities in access, the proposed regulations that are in the comment period right now would require plans to take action to try to reduce these disparities. So we strongly support these rules as experts in mental health and addiction parity. The comment period closes in under a month at the federal level. But it's important to recognize that even if these proposed federal rules are finalized, there's still urgent need to take action at both the state and federal level to improve the mental health and addiction systems that communities and families interact with every day. And commercial insurance is a critical piece of the equation. Commercial health insurance is a core component of any mental health and addiction system, and because if families don't get the coverage they need, costs are ultimately shifted onto them, as well as frankly taxpayers. And many families, again, simply don't have the resources to pay for services that aren't covered out of pocket. And so to expand access to services, health insurance is a critical part of the equation. But certainly there are many different components of the system that need to be changed in order to fully get people the help that they need. And so just to wrap up quickly, and then we're happy to take questions, of course. The federal proposed regulations comment period will close at the beginning on October 2nd. So in less than 30 days. And if the proposed rules are finalized, health plans will really have to do more to show, how they're complying with the Federal Parity Act and analyze data about, access to care. But, ultimately, this is only one piece of the equation. And other states are taking action, to improve their mental health and addiction systems, while these federal efforts are underway. And, I think that there's a broad recognition that we're in the middle of a mental health and addiction crisis, particularly for, our youth who have been very hard hit by the pandemic. And certainly there's an urgent need to improve access to youth mental health services, because by intervening early with appropriate services, we can decrease costs associated with untreated mental health conditions, and we can also decrease physical health care costs, because under treatment of mental health and addiction is a significant driver of all healthcare costs, because when these conditions are, untreated or undertreated, it's often impossible to control, physical health conditions, and people end up in emergency departments and become hospitalized when they really shouldn't be. And if they had received the mental health and addiction services, we could prevent, much more costly interventions, emergency department visits, hospitalizations, and can also decrease physical health care costs, which can increase dramatically when mental health and addiction needs are not met. So I'll kind of wrap up there, and just thank you for all your leadership on mental health and addiction issues. This is a critical issue, facing really every aspect of our society. There's really very little that these issues don't touch and impact. So it's critical that that Michigan has the Behavioral Health Committee, trying to address these issues and improve access to care, because we know that this is a huge concern in our communities, and that people need access to services now. Well over 80% of people support increased access to mental health and addiction services, and both state and federal action to make sure that occurs. And now is really the time to address these issues, to realize the promise of parity, and to take steps to help our families and communities who are suffering across Michigan and across our country. So Angela, I'll open it up to you if anything else to add. Otherwise, we'll open, happy to answer any questions that you may have. It's an extraordinarily important issue, and there's certainly a lot of action at both in the states and at the federal level to try to improve access to services.
Thank you so much for that, David. I'll just be brief and sort of summarize in more layperson terms. So David talked extensively about all the actions happening at the federal level, but I think the shorthand way to talk about it is that the federal government is working to refine a law that was passed in 2008. And the reality is, since the pandemic, families and individuals across this country, and certainly here in Michigan, really are worried about mental health. There is greater awareness of mental health needs than ever before. More kids hurting, more adults hurting, and people want access to mental health care. And the reality is that the federal parity law doesn't do what people expect that it did. So people routinely want access to in-network services, or if in-network services are not provided, the vast majority of voters across the aisle want insurance plans to cover the cost of out-of-network care without it being at an extra cost to that beneficiary. The other thing is that people across the aisle really support health plans using nationally recognized clinical standards of care when they're making their treatment decisions. And finally, that health plans are not cutting treatment short arbitrarily, that they're actually providing the care needed to get people well. So that's what we're here to talk about today. And it's really about improving access to care and ensuring there are basic protections in place for the many people who need that treatment. So thank you again for your time.
Thank you both. I really appreciate it. I want to open it up to my colleagues for any questions for our national experts here. I know I have some, but anybody? Do we have anybody online? Okay. So I have two questions. One, Angela, you talked about the Governor's Association releasing the Youth Mental Health Playbook. How do we find that, and what's the best place to find that? I know that there are some folks who kids' mental health is one of their top priorities, and so that would be great.
I will certainly send you a link to that.
Okay.
It's on the National Governors Association
Okay.
website, but it may be a little buried.
Okay.
It was just released in July, and so it is
great.
new. It is very extensive, but very easy to read and very accessible, concrete recommendations, including examples from states all across the country who are making real progress in serving youth.
That's great. Do you know, I have not had a chance to look at it. Do you know if they talk about in that playbook not only being able to serve kids, outside of school, but within school systems as well?
Oh, absolutely.
That's great.
In fact, that's one of the kind of key proposals is that we need to make mental health care more accessible
Yeah.
wherever people are at. And for youth, they spend so much of their time in schools. So it's a strong recommendation that there be school-based mental health as well as community-based supports and frankly, telemental health, which is bridging the gap for many rural areas.
That's really helpful. Thank you. I know that there are folks who do a lot of work on school-based health centers here and being able to provide that. So that's really helpful to hear. David, you were talking about integrated care, and I'm wondering what you're seeing kind of over time in terms of, I'm hoping it's the increase in providing integrated care. You were speaking about the implications for increase in mental health symptomatology and physical health. And so I'm wondering if you can talk about what you're seeing nationally around more agencies and even health plans being able to work from that kind of lens.
No, absolutely. Integrated care is really what everyone should have access to. People don't have their lives kind of neatly separated into mental health and substance use needs and to physical health needs. People want to have services delivered in the same place in a coordinated manner in a way that our system is frankly very poor at doing currently. And so there is an increasing push across the country to integrate services. There are things like the collaborative care model with Situate. There's essentially in primary care practices, Situate behavioral health, expertise, to basically help integrate care, because we know that over half of mental health services are actually delivered in a primary care setting by primary care clinicians. And so it's critical that we integrate care, because that's how people ultimately have their needs met, and we improve outcomes, we decrease costs. So it's enormously important. There are a few things we need to do to enable that to occur. We of course have to ensure that payment for integrated care is occurring. We also have to make sure that we're measuring what good outcomes look like for individuals, so that we can design payment models that support integrated care. Our current fee-for-service model often falls short there, and our systems for mental health and addiction services and physical health care services have developed in a very siloed manner and continue to be too siloed. So we need to break down those barriers so that people can get integrated services and not have to navigate such a frankly convoluted system that is often people fall through the cracks, particularly when they have mental health and substance use needs. It makes it particularly difficult to navigate complicated systems when these conditions by their nature often impair your ability to navigate systems that are already difficult for most people to navigate.
Yeah. That makes sense. I have one final question, and then I'll reopen it up for folks. One of the other issues, and you talked about this in your comments before, was about reimbursement rates. I know that's one of the things that I've talked with colleagues about as well. Can you speak a little bit about what's happening in other states around addressing reimbursement rates and how those reimbursement rates are set, and one of the things that, I feel like we've seen is that when folks understand what actually goes into the care, the actual care, then reimbursement rates can shift. But I don't know if that's just, something that's unique. And like I said, I would love to know what other states are doing to address this.
Yeah, reimbursement rates are obviously a critical issue because reimbursement rates affect, whether providers are able to, accept insurance. Because in many cases for mental health and addiction services, reimbursement rates don't even cover the cost of providing care, which means that many providers are almost forced to be out of network. And in many instances, to rely on patients who can pay, not go through their health insurance, which means that there's inadequate networks that people can't get coverage through their through their health insurance network, which is how how people should be able to get coverage. Is through those health insurance networks. So other states, it's honestly been a difficult issue to get at. There have been some, efforts to both at the federal level to have plans document, how they're designing their reimbursement rates. Those efforts have not so far been very successful. What a lot of states have been doing, though, is looking at how quickly should an individual be able to find in-network care, and if those in-network services aren't available, you're really requiring that their health insurance plan pay for those services out of network. So it doesn't mandate specifically that this is what the reimbursement rate has to be, but rather says that the health insurance policy, is saying that you'll be able to access services within that policy. And so if that's not occurring, that the health plan has to help the individual access services out of network. And that can actually, encourage, plans to increase their reimbursement rates in order to bring more providers, in network so that they have, timely access to care, within their health insurance network. The other thing that I think is really important on reimbursement rates is that there is overall we need more mental health clinicians, and no one denies that. But when reimbursement rates are very low, individuals who are considering going in to mental health and addiction care and become mental health and addiction clinicians frequently choose not to. And they may choose to go into physical health and may choose to go into other fields entirely. And so to increase the pipeline of new clinicians, we really have to do more to increase, reimbursement, so that people want to go into these fields. And once again, our underinvestment in mental health and addiction services is really costing us dearly everywhere else, both in terms of cost to society, as well as much higher physical health care costs. There was research recently by it's interesting, of all the people who did the research, by Moody's Investors Service, who had data showing that people who didn't get the mental health and addiction treatment they needed had 2 to 3 times higher physical health care costs, and that in order for health plans and insurers to help manage physical health care costs, they needed to be investing in mental health and addiction services, because those much higher costs show up elsewhere when we don't make these investments. And so that's certainly true for insurers. I think that's true for society as a whole, that when we're not making these basic investments in mental health and addiction services, the costs show up so many other places, and often they hit state and local budgets as well, in very profound ways that I don't think we fully appreciate.
Yeah, that makes sense. When you were talking, it made me think of one more question. Sorry, folks. One of the things that we've been talking about, particularly with around reimbursement rates on the private side, but I feel like the private side can be, and the health plan side can be impacted by the public side and how those reimbursement rates are set. And so I'm also wondering about what you're seeing across the nation in terms of those reimbursement rates, because I think that really weighs in heavily across the entire system.
There's certainly, many states recently have been trying to increase, Medicaid reimbursement. And that's really critical. And, it's in many instances in many states, there have been essentially whole generations of clinicians who have not received any increase in rates for decades.
Right.
Which, makes it impossible to improve access to services for people who are, rely on Medicaid, which actually Medicaid is the biggest, currently, the biggest payer of mental health and addiction services in the country. We actually think that many of those costs could actually be reduced if we had more appropriate commercial health insurance coverage, because many people, when their condition deteriorates, they lose their commercial health insurance because they frankly become poorer, and when they lose income, when they lose a job, and they end up on Medicaid. So I think we need to focus both on Medicaid and increasing access to Medicaid, but also the commercial insurance component, has effects on state Medicaid spend as well.
That's really helpful. Thank you. Rep. Reingans.
Thank you. I wanted to make some comments about reimbursement rates. I used to work at Michigan's Department of Health and Human Services in the substance use disorder area. And one thing that we heard consistently from our prepaid inpatient health plans about rate setting was that the way that rates were calculated for future years were based on previous years. And therefore, you start at a lower base by default. And so I've always wondered what it would take to create a new kind of actuarial system to reset rates based on the amount of work it takes to provide the various services, and then also consider how many behavioral health conditions are treated in a kind of ebb and flow manner, where it has to be highly individualized to a patient and their ever-changing needs. Whereas some things in physical health are very much more routinized. I've had 2 ACL reconstruction surgeries, and literally both times I just had the same amount of physical therapy. It was like pretty well calculated. We knew what it was going to take. But with some behavioral health conditions, it's you really never do know how long it's going to take, how many days you truly need, how much intensive services. So it is a little bit harder to calculate for actuaries. So do you have any evidence or any in the last couple years improved or different ways of setting rates based on the costs that it may take for various services, for various care levels too, I guess? It's like a huge matrix.
Yeah, no, I think it's an excellent point that, the mental health and addiction systems, we're very siloed and, heavily stigmatized, as, for a long time. And when we base current reimbursement rates on what's been in place historically, we just kind of perpetuate those low reimbursement rates. So there has definitely been interest in this question at the federal level. There is increased interest in the Medicare fee schedule, which actually is really instrumental in setting in kind of a benchmark for rates across the country. So their efforts to address those mental health and addiction rates at the federal level. One area that I think is important to look at is so when we have in-network providers and out-of-network providers, you can look at what the in-network rate is, what people are being paid in-network for mental health services versus physical health services, and then look at what people are paying for out of network, and see essentially what is the difference between those. And if someone needs a cardiologist, they find a cardiologist in network. they don't have to go out of network to find a cardiologist. And in fact, I'm not aware of any private pay cardiologists. There are a lot of private pay psychiatrists, and it's largely because in-network reimbursement is so low, and essentially the market rate out of network is much higher, which kind of shows that supply and demand at work. So it's important to look at those market signals too, particularly in the context of commercial insurance, because I think that can be illustrative of where disparities are.
I understand taking a look at in-network versus out-of-network rates. I'm not asking for that. I'm asking for how much does it cost to deliver this service? And can we use that as a baseline instead of historical low rates?
Yeah, certainly.
So maybe the out-of-network folks might charge a little bit more because they can, so like it's not necessarily reflecting the actual cost. So how is, is there a way to check the actual cost of delivering the services in some sort of unit that makes sense?
Yeah, there at the federal level, there are efforts to improve, particularly in Medicare, the federal program, how those rates are set, and looking at the actual cost of delivering services. I think we're just at the beginning of addressing some of these long.
Is that divided by age in some way that reflects the general population? Because the Medicare population is not reflective of the general population, particularly as we were talking about youth earlier. How many youth are on Medicare? They only qualify for Medicare if they are extremely in a very unhealthy way or disabled in some way that they would qualify.
And I'll say I am not an expert in rate setting at all, but what I will sort of throw out there is that the certified community behavioral health clinic model is doing a lot to address those payment disparities because reimbursement is on a cost basis, and it sort of mimics the sort of reimbursement structure that federally qualified healthcare clinics have for years received. And that allows clinics to more accurately receive the kind of revenue that reflects the actual costs of delivering those services. And that has helped FQHCs over time really provide robust services in a lot of communities and sustain, whereas community mental health programs have historically been subject to a lot of ebbs and flows in terms of their revenue that doesn't necessarily match the cost of providing that care. The CCBHC model is designed to overcome that, and as you're pointing out, more accurately reflect revenue that matches that cost of care delivery.
Thank you both. Are there any other questions for our speakers today? Well, seeing none, I want to say thank you to both of you so much for offering your perspective on various things that are happening, and it's helpful for us to hear of what's going on across the country and other states around all these various issues, whether it's youth mental health, parity, reimbursement rates. It's really helpful for us to think about then how we can work on these issues right here in Michigan. And one of the things that this, mental health, as you all know, is a really complex, complicated, multifaceted issue that takes many solutions. And so being able to hear about this and think about solutions for us and not having to reinvent the wheel every time is something that's really helpful. So thank you both so much. We really appreciate you being here and lending your expertise. So we just have a couple housekeeping items, folks. Minority Vice Chair Schmaltz makes a motion to excuse absent members. Seeing no objections, that motion is adopted. Anything else before we adjourn? Okay, this meeting is adjourned. Thanks, everybody.